And we certainly appreciate everyone's support. This is the fourth lecture of our series. As you may know, we started last year with a series of lectures, and the first idea was to talk about prevention. Obviously, we've talked a lot about breast cancer, but we also wanted to talk a little bit how to prevent breast cancer. So the first series of lectures, as you may remember, focused on exercise, diet, nutrition, and mindfulness, and was a very well attended lecture. I wanted to remind you that all the lectures are actually on our website. So our website is atlantabreastcare.com, and if you click on the little tab that says Patient Info, all the lectures will be found there. And the idea, obviously, is to build a library of lectures that will be a help to educate our breast cancer patients to make their journey through this process a little easier. The second lecture, of course, was on human genetics with Molly Klein. She did an amazing job. And then we had a wonderful event over at the Botanical Garden that one of our patients, Hollis Younger, spoke about attitude is everything. And some of you may know Hollis. Hollis is a very young patient that was diagnosed with inflammatory breast cancer that unfortunately has been on and off chemotherapy for the last 5, 6, 7 years. Hollis is a young mom. She's got an 8-year-old, and she's one of our miracle people, and a dear friend of many people that live in Atlanta, and was kind enough to come from Brunswick, where she lives with her husband, who's an architect, to speak for us. But don't hesitate to look these lectures up on the website if you don't mind. I wanted to thank my partners, Dr. Aaron Bowman and Dr. Alex Deal, and I'm actually going to formally introduce them in the talk and tell you a little bit about them, but I appreciate all their help. Paula DeMarini, as our Director of Marketing, has been a big help of putting this together, and we're grateful for her help. Nancy Babbitt is our office manager and practice consultant, and we're grateful for her help. Jennifer, our nurse, as you may know, recently moved to Fort Worth, Texas. And we'll talk about that a little bit more, but Jennifer's working remotely for us from Fort Worth, and we appreciate her help. Kelly Lofton with the foundation is here, and Kelly helps keep us straight and has really done a great job of helping us run our fund so that we can use it to the maximum benefit of our patients. Of course, we want to thank our donors. This was started by an anonymous donor with a very large gift that is a great thing, because some of the things we're doing now we had talked about for about the last 10 or 15 years, and it takes someone like that to help motivate you to actually do something about it versus to talk about it. So the idea is not only to continue these community lectures, but we have other parts that the fund is doing through the foundation that we'll talk to you about, all directed at helping breast cancer patients. And there was an event last summer called the Short Shootout. That was another gigantic donation to the fund, which is a golf tournament put on by Lisa Short and her husband Herbert, which will be in the fall. And I think that's been moved from the summer to the fall. I guess her son maybe is getting married this summer, and so I think their house is going to be busy this summer. But we appreciate your help. Dr. Adam Nowlin is here tonight. He's the medical director of radiation oncology, and somebody that many of you know. And Dr. Sinha, Rajneesh Sinha, is kind enough to come tonight to help us answer medical oncology questions. I mean, when I answer those questions, people say, Bill, I appreciate that, but why don't you stick to the surgery and leave the answers to some of those questions to us? So I appreciate her being here to help answer some of the questions related to medical oncology. Obviously, we want to thank our patients for being here. I mean, the whole idea here is to have a better understanding of breast cancer and to educate our patients so this journey together can be easier. I think our practice does our best to take a unique approach to really be available to our patients and spend the extra time with our patients. For most people, this is one of the scariest things that has happened in their life, and our job is to not only offer you the best care and treatment that you can find anywhere, but also to be available for phone calls and be available for your support, and actually to organize your care and put the whole care together for you. As we've gone through this process, breast cancer has changed a lot, and the choices are many greater than they were, and the outcomes are improved. And it depends on whether those outcomes are related to chemotherapy or radiation therapy or medical oncology or surgery. There have been dramatic changes, and But, you know, the outcomes have improved so dramatically. When I was in medical school, there was only a mastectomy. There was not a lumpectomy. There was no reconstruction. And the first time I saw a mastectomy, I really wasn't even sure what was happening. And I asked a question, and they told me. And I said, why would you do that to someone? That does not seem like a nice thing to do to someone. And he said, and I said, well, is there any possibility you could ever remove the tumor with just a zone of normal tissue around it? And he said, you know, you are an idiot. And he said, you are an idiot and you are in my way. Move to the end of the table and just move. Don't ask any more questions. So that was how that question about other options for breast cancer was received at the time. But let's get started. And so the idea tonight is we get asked a lot of questions about breast cancer, and many of the questions are overlapping. And so we thought we would run through some of the most frequently asked questions, and then we'll answer your questions at the end. And I'll try to explain the answers to some of these questions in a way that hopefully is understandable. And if I'm not explaining it in a way that's understandable, please raise your hand and tell me to do a better job. So the first thing we'll talk about is tumor biology, and you can go to the next one. People always want to know, first of all, what causes breast cancer? And basically, to oversimplify it, a cell in the breast mutates. And it's the job of the cells next to it to either recognize it as a mutated cell and repair it or replace it. And the cells in your body are constantly repairing and replacing themselves. And when you wake up in the morning, all the cells that line your mouth are all new every 24 hours. So the body is constantly repairing itself. And somehow the body forgot how to take care of that mutated cell, and one cell becomes 2, and 2 cells become 4, and 4 cells become 8. When people come to our office, they frequently think they may need to have surgery in the next 24 hours. You know, you can't really average things that have varying growth rates, but on average, the breast cancer may have started 7 years before we met the patient. So operating the next day is not really the best idea. We want to put multidisciplinary treatment together and get medical oncology, radiation oncology, medical genetics, and everyone involved. But the types of breast cancer, so the first and the most common is infiltrating ductal. And the word infiltrating scares people. It's also called invasive. They mean the same thing. And it doesn't mean that it has spread. But if you envision the milk ducts of the breast, there's like 8 to 12 terminal ducts that come to the nipple. But in the periphery of the breast, it's like the branches of a tree. So the individual duct is like the trunk coming to the nipple for the purpose of breastfeeding. So if that duct is like a straw, there's cells that line the straw. And if those cells become malignant, if they stay confined in the duct, but they've not grown through the wall, that's a stage 0 breast cancer. That's a DCIS, meaning in place. So they haven't broken through the wall. So if they haven't broken through the wall of the duct, there's no access to blood vessels or lymphatics, so there should be virtually no sense of spread. Now, infiltrating or invasive does not mean what it sounds like. I mean, it sounds like it's already spread and something really bad's getting ready to happen. But usually, fortunately, it does not mean that. It simply means it's broken through the wall of the milk duct, which is like a straw. And when it breaks through the wall, it doesn't mean it has spread, and it doesn't mean it's going to spread, but it means it could. Because the 2 most common potential routes of spread are either through the bloodstream or through the lymphatics. And the blood vessels and the lymphatics live just outside the duct. So when some of the cells break through the wall, they could conceivably spread. So infiltrating ductal means it's broken through the wall. That's about 70 to 80% of our patients. It means that the cells originated in the milk duct. So people always say, how do you know this is breast cancer? How do you know it didn't spread from another part of my body to the breast? Well, the first thing is it's a ductal cell. I mean, it's a breast cell. It's a breast milk duct. So it has to be a breast cancer. And carcinoma means it's malignant, and it has the potential to replicate and possibly spread. The second most common type is lobular, and the breast lobule is where the breast milk is made, and it's probably only about 15% of our patients. So there's a big drop-off between the most common type and the second most common type. And lobular breast cancer is an infiltrating breast cancer. Unfortunately, can also potentially spread. The single biggest difference for ductal and lobular in one respect is the imaging characteristics. Ductal is more commonly seen on a mammogram, and lobular breast cancer, unfortunately, can conceivably never be seen on the mammogram. So it's conceivable that a patient could have a fairly sizable lobular breast cancer and have had a normal mammogram the day before they saw us in the office. And the idea is the amount of disruption of the breast parenchyma. And lobular breast cancer can potentially be more like finger-like projections through the breast, so it won't disrupt the parenchyma of the breast as much, so it's not as obvious on a mammogram. Hence the importance of doing breast MRI and some of the other things we do. So ductal, lobular, and then the stage 0 is DCIS. Obviously the cure rates for stage 0 should be 98, 99% or so. Should be completely curable. We'll discuss some of the treatment options, and then more unusual types, medullary, metaplastic, and some others. And when you hear about a patient that has inflammatory breast cancer, that is one of these variants, but it means that it's unfortunately growing very quickly typically, and there's a redness to the breast. The breast almost looks infected. And unfortunately on some of those patients, it will spread in a matter of days through the skin. People think it's spreading to the other side. It's actually spreading beneath the skin more than anything. So what are receptors, oncogenes, and growth rate? So this is about tumor biology, and tumor biology has a lot to do with how we think you may do and what your treatment options may be. And the first is estrogen. And everybody says, so does this mean that estrogen caused my breast cancer? And medical oncology will help me, but basically my feeling and understanding of that is no, it doesn't mean that the hormonal replacement therapy that you took actually caused your breast cancer. It didn't cause the mutation, but it's created an environment that makes it easier for it to develop. And if you have a strongly estrogen receptor positive breast cancer, if you're taking estrogen, unfortunately it could make it easier for those cells to replicate and grow and potentially spread. So estrogen receptor positive breast cancer is, we're going to talk about 4 receptors. The first is estrogen, and those numbers go 0 to 100. And let's say your estrogen receptors are 50, that means 50% of the cells have estrogen receptors. If your estrogen receptor number is 100, 100% of the cells have estrogen receptors. The numbers go 0 to 100, the higher the number, the more favorable. So estrogen receptor 0, none of the cells looked at under the microscope have a protein on the cell surface that metabolizes estrogen. So estrogen receptor 100 is favorable. The next is progesterone, which is a downstream expression of estrogen. If you're strongly estrogen receptor positive, you would like to be strongly progesterone receptor positive. That number also goes 0 to 100. The next is something called HER2. And a lot of people have heard of this, HER2/neu, and it's got a fancy name, and it's called an oncogene. It's also a protein on the cell surface, but the thing that makes it easiest to remember is it's a growth factor, an epidermal growth factor. So if you have a teenage boy that's lifting weights that maybe wants to gain weight to play football, a growth factor might be a good thing, but obviously you would prefer not to have a growth factor on your cancer cell. So HER2/neu positive patients, which is approximately 20% of our patients, unfortunately experience a slightly potential higher chance of the cancer spreading or the cancer coming back. So there's a very specific type of treatment for those patients that turns off that growth factor. And this is called immunotherapy. Those drugs are typically Herceptin and Perjeta. So I'm probably going fast because, as my wife says, Bill, you understand this. You know, people don't understand this. You're talking way too fast. But HER2/neu is a growth factor that you want to try to turn off. And so there is a drug or drugs that actually bind that growth factor and turn it off. Now, it's normal to have some of the growth factor. What is not normal is to have an overexpression or over-amplification of it, so you're trying to turn that off to minimize the chance that the cancer will come back or spread. So that's HER2/neu. So when we go over these reports, you know, people say, what was your estrogen receptors? People say, I don't know, it's 0 to 100. What were your progesterone receptors? 0 to 100. Those numbers are important. Were you HER2/neu positive or negative? That's extremely important. And then the Chi or Ki67 is a protein associated with cell proliferation. So one of the patients I saw in the office this week had a Ki67 of 95%. She's 89 years young. That's very unusual. She has a growth rate that is, the numbers go 0 to 100, is an outrageously fast-growing tumor. Her cancer is a metaplastic cancer, and these tumors are tough tumors. It's a tough tumor to take care of. We see patients that have tumors where the proliferation cell rate is 5% or 10%. Those are much slower growing tumors, and they're typically associated with better overall prognosis. But anyway, so remember for HER2/neu, there's monoclonal antibodies that turn off that overexpression of the growth factor that have dramatically improved patient survival. And there's even phase 3 clinical trials now for monoclonal antibodies for patients with spread of HER2/neu disease that is very hopeful. So surgical treatment options, you can go one more beyond this. Obviously, these treatment options are lumpectomy versus mastectomy. And, you know, people say, how in the world do you decide? Well, first of all, lumpectomy is best designed for one tumor versus two. So the idea is, how many tumors do you have? Hopefully one. What's the approximate size of the tumor? Where is it located in the breast? And without being inappropriate, how large is the patient? So, I mean, a large tumor in a small breast makes the lumpectomy a little bit more difficult. Some of those patients actually need chemotherapy or hormonal therapy prior that might shrink it, that may still increase their chance of having breast-conserving surgery. But it kind of makes sense if you think about it. Do you have one tumor or more than one tumor? Where is it located in the breast? For example, the majority of the breast tissue lives in the upper outer quadrant. So it's easier to do a lumpectomy in a patient that has a primary tumor in the upper outer quadrant because the tissue is more forgiving there, and the final cosmetic result will be more forgiving. So it matters the location. Is the disease localized or diffuse? For example, stage 0 breast cancer, the DCIS, very early, very curable, but it can have a tendency to spread out and to go through the milk ducts and actually cover a large area. So one time I saw a patient with DCIS that had DCS throughout the majority of the breast, and she said, my next door neighbor told me to ask you, why in God's name would you be considering a mastectomy for stage 0 breast cancer? And so there's this confusion between localized disease and diffuse disease, and is this a serious problem or not? But it has to do, if the cancer has taken up the majority of the breast tissue, we can't really preserve that breast, unfortunately. So the risk in that case is more to the patient's breast than it is to the patient. You would expect that the patient's going to have an outstanding survival, little chance of spread. It should be very curable, but that's more of a breast-related issue. There's some interesting things happening in the future, and Aaron Bowman, one of our partners, has participated in some trials with cryotherapy for benign tumors in the breast, and it's also being looked at, believe it or not, for malignant tumors in the breast. So there's some ongoing trials to see if you can have a probe placed in your breast in your breast cancer surgeon's office, freeze the tumor, turn off all the blood supply to it, and just have a sentinel lymph node biopsy under your arm. So your only surgery, instead of removing the tumor, and this is not ready for use now, but it's being investigated, would be to have the lymph node under your arm checked. Now, in the early parts of the trial, of course, you freeze the tumor, but you still have to operate on the patient and do a lumpectomy to determine if there's viable tuber remaining. But a lot of breast cancer surgery is becoming more image-guided, more percutaneous. There's a group in Japan that's looking at radiofrequency ablation of cancerous tumors in the breast. Now, if those things work, I mean, it's conceivable the patient would not need a breast operation. They might still need a check of a lymph node on the arm to make sure there's no spread. But I mean, they could conceivably have this procedure, have radiation, not have to have a surgical lumpectomy, not have the deformity that hopefully doesn't occur, but sometimes occur with breast-conserving surgery. Sometimes there's volume loss that can create an issue there. What's the risk of recurrence in lumpectomy and mastectomy? Surprisingly, they're closer to the same than you think. Almost everybody thinks the risk of recurrence with a lumpectomy is significantly more than a mastectomy. They're actually fairly close. It has a lot to do with these tumor biology, how close was it to the skin, did you receive radiation therapy and that sort of thing. But there's not a huge difference. It may be slightly higher in the lumpectomy patients because they preserved their breast. And in mastectomy patients say, how in God's name could it come back? I had a mastectomy. What do you mean it could come back? Well, you have, unfortunately, the slight chance of it coming back on the overlying skin. There are microscopic cells that live all the way to the collarbone, all the way to the mid-sternum and here. So it's obvious what the shape of the breast is, but there are cells that go beyond it. Unfortunately, a cancer cell could be potentially embolize to the skin, even in surgery, and live on the skin flap of a mastectomy for 10 or 15 years and never have a problem, and then one day it's back. And people say, I'm a little confused. How could I possibly have recurrent breast cancer? I thought you did a mastectomy. And that is confusing. And heaven forbid, when it comes back, it's almost always at the exact same site on the skin flap where the original tumor was. And so that can either be called cutaneous or subcutaneous recurrence. It should be a completely curable event. It's not normally associated with distant spread, but that needs to be checked to be sure. If you've had a mastectomy and heaven forbid that occurs, typically that lower area needs to be removed, and most of those patients would typically also need radiation. So we said survival is the same. There's one other thing I want to mention. Triple negative patients. What in the world does that mean? Estrogen receptors are negative. Progesterone receptors are negative, and the HER2 is not amplified. So that's called triple negative. Everybody acts like it's one type of breast cancer. It's probably 20 or 25 types of breast cancer. So you can see we still have a lot to learn. But triple negative can sometimes have a worse prognosis. Those patients potentially do better with lumpectomy than with mastectomy, probably because of the radiation therapy that is added to the lumpectomy. So it's conceivable that some of the mastectomy patients in the future with triple negative may have an increased rate of getting post-mastectomy radiation. But the lumpectomy is a local procedure. It's local. The radiation is local regional. So the radiation affects the breast, but in triple negative and in other cases it can help by decrease the chance of breast cancer coming back in the lymph nodes above the collarbone. There's some hidden lymph nodes just inside the chest called internal mammary and lymph nodes under the arm. So it's conceivable that there may be some emerging data that suggests triple negative patients may actually do better with lumpectomy and radiation than they do with mastectomy. How's a lumpectomy performed? This is a picture of the clip. You know, people, when you have a biopsy and we place a little clip there and everybody says, please don't put that in me, and why are you putting that in me? Well, and why would you need a clip? I mean, what is wrong with you? I don't want a clip. So you probably don't want to be seeing us, period. You probably would prefer to be somewhere else today. But the clip is a help for a lot of reasons, but you can see this clip is in the center. So the idea of a lumpectomy, quite frankly, as you can imagine, is to put the tumor in the center of the target. I mean, you want a zone of normal cells around it. And unfortunately, that doesn't always happen. And people always say, you know, were you okay that day? How did you not get perfect margins? Is it that complicated? And it's more about us not having a bad day. We're very familiar with how to perform the surgery. Not every tumor is a perfectly round marble in the center of a larger structure. Some of the tumors have microscopic finger-like projections that come off of the tumor, and people wonder why you don't measure those margins in the operating room, and there's about 100 reasons, but 2 or 3 reasons is the frozen section margins are horribly inaccurate. They take a long time, and it's just not practical. So those margins are measured on the final specimen, and unfortunately, a small percentage of the patients actually have to go back to the operating room and have another margin re-excised. The good news is we ink the margins, paint the margins, so there's 6 margins. So instead of having to re-excise the whole lumpectomy cavity, you just go back and re-excise the margin that was too close. All right. What is an oncoplastic reduction? So there are some patients that say, you know, all my life I have been thinking about having a reduction. Now I have breast cancer. An oncoplastic reduction is a procedure that meets all sound oncology principles, but also allows the patient to have a very cosmetic procedure simultaneously. Plastic surgeon is obviously involved. A board-certified plastic surgeon that helps us manage our breast cancer patients does the oncoplastic reduction, not just on the cancer side, but on both sides for symmetry. This is an amazing procedure that can prevent some patients from having a mastectomy that don't want or don't need a mastectomy. It has the added benefit of being able to obtain additional margins because the patient says, you know, I'm very large, I want to be smaller, and it actually helps you get extra margins. So the plastic surgeon is able to help rearrange the breast tissue to allow you to do a very adequate lumpectomy while they do a reduction on both sides. We frequently place a biosorb device at the lumpectomy cavity to help Dr. Adam Nellen and his team know exactly where the lumpectomy cavity is so that he knows how to angle the radiation beam. Because in a reduction oncoplastic reduction, the incision may not be exactly where the tumor was. And Dr. Nall and his team need to know exactly where the tumor is to be able to, determine the appropriate physics and angles for radiation. Different types of mastectomies. People ask a lot about this, and this has changed completely. We've gone from these much larger incisions way over here to, depending on where the tumor is, a skin sparing. Skin sparing can mean a lot of different things. This is just one example of skin sparing where all the skin spared, but the nipple areolar complex is removed. And then a nipple sparing procedure. And nipple sparing means the nipple spared, the areolar skin spared, all the overlying skin spared. So you just go beneath the skin, remove all the breast tissue. Now this works best, obviously, if the primary tumor is not dead center in the breast and close to the nipple areolar complex. You actually have to take an additional specimen right beneath the nipple and make sure there's no atypical cells there. I mean, you don't want to go to the trouble of have a mastectomy and then have a recurrence right beneath the nipple. So you actually take a small piece of tissue, make sure there's no residual cancer cells there. And those patients, those patients don't need continuing imaging like mammography, et cetera, but they do need continued follow-up in the office. We actually continue to follow all of our patients, but these patients in particular, because they have to have a tiny disc of breast tissue saved beneath the nipple to keep the nipple alive. It's not so much that we're worried about the nipple, but there is a very, very small disc of breast tissue about the size of a dime or nickel that keeps the nipple alive. So those patients are followed in the office by physical exam and ultrasound to make sure that tissue stays healthy. When breast cancer develops, only 2% of the time does it develop right behind the nipple. So this is considered to be a very safe operation and very oncologically sound. MRI is important. It's important that the MRI look normal right behind the nipple, but this is a gigantic advance for patients as far as mastectomy. We've come from removing a tremendous amount of skin, removing everything, not having immediate reconstruction, to possibly having a nipple sparing procedure and having so our practice has a tremendous experience with this, and I'll be honest with you, some people are better at this than others, and it's nice that people have done it before and assist each other in these procedures, but this procedure is a little bit trickier than some of the others. It's very important that you know how to maintain the blood supply to the nipple. It's extremely important that all of the breast tissue be appropriately removed. And if somebody is not perfectly experienced in this, one of the risks is that if they're operating, say, through an inframammary fold incision down at the bottom, if they can't see perfectly well, have they inadvertently left breast tissue behind. So this is an operation that is very important that the practice have extensive experience with and feel very comfortable with. So reconstructive options have changed dramatically and fortunately improved and improved and improved. So first of all, everybody knows there's something called tissue expanders and implants. And an implant is a tissue expander that's not completely filled. It's gradually filled over time, and then the tissue expander is typically taken out and a permanent implant is placed. Those always went beneath the muscle. Now sometimes they can go above the muscle. Depends on a lot of different circumstances. If they can go above the muscle, the recovery can be much quicker and much less uncomfortable. It depends on the thickness of the skin flaps, it depends on the patient, it depends on lots of different things, but tissue expanders or implants that can go above the muscle is less uncomfortable. There's a little bit of a chance that it improves the appearance upper inner. There's a chance that it may help range of motion issues with the arm. Certainly recovery is quicker, but it's up to you and your plastic surgeon if you're an appropriate candidate for that. So everybody in Atlanta used to always talk about the tram flap. And the tram flap was invented here, and I think it was a brilliant idea, but I don't think it worked out so well. And the reason it didn't work out so well is that you lose your abdominal core. And as we age, not only do we need our abdominal core for your abdomen, you need it to support your back. And unfortunately, let me back up. Cosmetically, the results of that can be incredible, phenomenal. However, I'm not sure I would want to give up my abdominal core that I may need to rely on more and more later in life. Some of those patients have had really significant problems with abdominal wall weakness, bulging, having to have repairs with mesh and all sorts of things. So there's a better way. There's a team at Piedmont that is expert at doing this. This is not something you can learn on the internet at night. This is a microvascular procedure that requires extensive training and expertise, that is done well in some places and not done well at other places. And we have a team here led by Grace Maw and her partner that perform this, Lindsay Webb. And they do an amazing job. And it would It's not my idea of a good time. I'm glad that they're good at it, but looking in the microscope for hours and getting a perfect result is well suited for extremely detailed oriented people that are very bright, that have practiced and know how to do microsurgery. I prefer operations that are a tiny bit quicker than that, but the good news is they're experts at that. So that is something that's here, and I'll be honest with you, our patients have been extremely pleased with that. So what's the difference? You lose the skin and you lose the soft tissue, but you do not lose your muscle. And you need, there's a muscle here called the rectus. There's one here called the rectus. Your life will go better if you get to keep them there. But if they become a tram, you've lost that muscle and it's now a breast. And for the remainder of your life, if you do both sides, you will not be able to do a normal sit-up. So when you're on the exam room in our office, 100% of those patients reach out for your hand to pull themselves up. So we prefer the deep flap. All right, what is a sentinel lymph node biopsy? So this is the gatekeeper lymph node under the arm. This tells us whether there's been any spread or not. Fortunately, gone are the days, the majority of patients where we no longer have to remove all the lymph nodes. If that lymph node is positive, and next slide, and the patient's having a mastectomy, they may need an X-ray dissection where the fat pad under the arm is removed. Every single patient says, how many lymph nodes are you going to remove, or how many lymph nodes did you remove? Unbelievably, we do not know until the final report comes back. And the reason is because the extra lymph nodes are hidden in the fat pad, but there's a way to do this procedure that protects you from cancer, but also helps minimize the risk of lymphedema or arm swelling. What is lymphedema? If you have this, you want to call 1-800-GWEN. Gwen is our physical therapist here who is an expert at lymphedema, and our patients think the world of her. She does an amazing job. And the first thing with lymphedema is prevention, and then the next thing is treatment. But most of this can be prevented. But if you've had a lot of lymph nodes removed under your arm, and you've also had radiation, unfortunately, you may be at increased risk of lymphedema than other people. So an ounce of prevention is worth a lot. You meet with Gwen. It's probably an hour-and-a-half appointment. She'll have a sleeve made for your arm. She'll teach you what high-risk activity is and how to reduce the risk of arm swelling. Prophylactic mastectomy. BRCA-positive patient, extremely strong family history, a patient that's had 4 biopsies in the breast center, all of which show atypia, that says if you send me up there again, I'm going to physically harm someone, maybe you. So if you put together family history, atypia, multiple image-guided biopsies, surgical biopsies, people say, Bill Barber, you probably will never go through this. Do this to me one more time. Unfortunately, people meet certain criteria for preventive mastectomy. We can calculate your 10-year risk and your lifetime risk of getting breast cancer. And if it exceeds certain numbers, it's appropriate to consider preventative mastectomy. We don't race to the operating room and do preventative mastectomies. The first choice, of course, normally would be close surveillance, and our ability to surveil patients has gotten significantly better than it was before with the help of breast MRI and other things. And with the help of medical oncology and hormonal therapy, you can dramatically reduce your risk of getting breast cancer and potentially prevent having to have preventative mastectomy. Genetic testing, we've had a whole lecture on that. So the number of patients that qualify for genetic testing is increasing. The reason I put this slide here is every patient comes in and they say, should my daughter have genetic testing? Well, the first thing is the patient should have genetic testing. And if the patient's negative, your daughter actually does not need to be tested. If your patient is positive, your daughter and your son and other primary degree relatives will be tested for that exact mutation. So that testing becomes much more accurate and much less expensive. Some forms of genetic testing have dropped from $4,200 to $250 for extensive panels. Some of the patients that don't qualify for some reason with the insurance company are paying for it out of pocket. High-risk clinic. So once we calculate your 10-year risk and your lifetime risk, a lot of these patients need to be followed. They're followed in our office, physical exam, screening ultrasounds, 3D tomosynthesis mammography versus regular mammography, potentially even breast MRI to make sure patients don't have to worry about developing breast cancer, or if they do, certainly that it would be found early. Follow-up. Lumpectomy patients are typically, this varies a little bit, we're typically seen every 6 months for 5 years and then yearly. Mastectomy patients are seen kind of similarly every 6 months or yearly. It's more likely that the mastectomy patients may be followed yearly than at 6-month intervals, but it depends on high risk and their comfort level and that sort of thing. What can I do to lower my risk of breast cancer coming back? So it's interesting. There's a fair amount of data that says if you exercise during chemotherapy, your risk of cancer coming back is improved. We've had a whole lectures on diet, nutrition, and exercise. That lecture was combined with mindfulness. Hormonal therapy after your treatment significantly lowers your risk. So just think that you've had a lumpectomy, not a mastectomy, and someone recommends you take hormonal therapy. And there's several things it's going to do. It's going to reduce the chance of the original cancer coming back. It's going to reduce the risk of the original cancer spreading. It's going to reduce the chance of another cancer developing in that breast, and it's going to reduce the risk of a cancer developing in the opposite breast. So hormonal therapy can decrease your risk of lots of these related problems. But as far as reducing this risk, some of these are kind of logical, but the Cancer Wellness Center here is a tremendous help in helping our patients know what these risks are. Will I need chemotherapy? So a long time ago, almost every single patient that had breast cancer that had a tumor over 1 centimeter, 2.5 centimeters equals an inch, 1 centimeter, they all got chemotherapy, regardless of their lymph node status. We have evolved so much. There's genetic testing, and there's genomic testing. Genomic testing is the expression of the genes in your tumor. Are they overactive? There's a 21 gene test called the Oncotype DX that can be used for node-negative patients and potentially node-positive patients with 1 to 3 lymph nodes that are estrogen receptor positive patients. So if you're estrogen receptor positive and the Oncotype DX can determine 2 things. It can be a predictor of the risk of your cancer coming back, and then the prognostic portion of this genomic test is the potential benefit from adding chemotherapy to hormonal therapy. And some patients with additional positive lymph nodes or even just a lymph node positive patient, the medical oncologist may prefer to use a test called MammaPrint. It's a 70 gene test. MammaPrint is either low risk or high risk. These are both gene profiling tumor tests to help determine 2 things: risk of recurrence and potential benefit of adding chemotherapy to hormonal therapy. Now, these tests are typically not done in HER2 positive patients and triple negative patients. Is that correct? So HER2 positive patients, if the tumor is over a certain size, unfortunately, they're probably going to need treatment. Triple negative patients, tumors over a certain size, they're probably going to need treatment. So this is primarily estrogen receptor positive patients. There's another way to think about this. It's helped save a tremendous number of people chemotherapy that likely won't benefit from it. So they're saved the toxicity of chemotherapy. So this is about personalized medicine. This is a dramatic advance from the way things were when I started in this field, where, I mean, obviously, if I had to go through something like this and had to have chemotherapy, I would love to know there's a gene test that said you really, really need it versus just someone's opinion that said, you know, I think you should do this, because you really want the statistical evidence to support if you're going to go through something like that. Hormone therapy, I think you know what that is. Below the age of 50, frequently tamoxifen. After the age of 50 may be an aromatase inhibitor like Arimidex. We'll let you ask some questions about that if you have that to Dr. Sinha. Everybody wants to know, my wife said one of the first questions she would ask if someone told her she had breast cancer would be, am I going to lose my hair? And my wife doesn't spend a lot of time looking in the mirror, but that's an important question for people, and so there is a way to get around that. And it's you know, we started out with cold caps, and then we have DigniCaps, where there's a program here to help patients preserve their hair. All right, how do you select a breast surgeon? So you're looking for a practice that's specialized in breast. You're looking for breast surgeons that are specifically trained in this, that have the appropriate judgment and technical skills to do the right thing. What you're looking for is someone that can cure you and someone that knows how to work with the team to minimize the chance that your cancer will come back. The plastic surgeon is kind of similar. What procedure are you interested in? Do they do that procedure? Do they take your insurance? Is their office comfortable taking care of breast cancer patients? Or heaven forbid, are they trying to look forward to the next facelift or something like that? So the doctors that we use in plastic surgery are interested in helping people save their lives, be restored after mastectomy, and they're not interested in trying to sell you the next procedure. They're dedicated to that, and you can feel that in their offices. Do you need to go to MD Anderson? Of course, we hear this occasionally. And the answer to that is MD Anderson came to you. And so Piedmont is an MD Anderson certified hospital. It's Georgia's first and only certified member of the MD Anderson Cancer Network. So they have certified us, and they check over our records carefully and make sure that you're doing a good job. The other benefit of that is the opinion that you got from the medical oncologist here is probably all you need. But the word cancer is not a great feeling. And once somebody hears the word cancer, many times the first thing your next door neighbor says is, where did you get your second opinion? Well, MD Anderson has provided a service for us where you can get a peer-to-peer review within 48 hours. And if you like to fly to Houston, it's a busy place. People from all over the world are trying to go there, and it's not the easiest thing to get on their opinion. But not only can you get the appropriate answer from the experts here, who I would feel comfortable taking care of me or my wife. Everybody says, how about your wife? How about your daughter? I said, we would never send a patient to anyone that we weren't comfortable taking care of ourselves. I would feel completely comfortable with that opinion. However, there are some complex situations. And, quite frankly, they're more commonly medical oncology complex situations than there are surgical, but you have that option. Who is Emma Stein? Emma Stein is here tonight. So people say, what about psychological support? This is more than just breast cancer and medical oncology and radiation oncology and reconstruction. I guess getting a phone call that said you have cancer feels worse than saying the IRS is knocking on your door and the police are with them. Those are both bad feelings, but the word you got cancer does not feel good. And Emma Stein has specialized. She's a doctorate in clinical health psychology. She specializes in psycho-oncology for cancer patients. Now, to me, that is a specialty. And if I had cancer, I would say, oh, my God, there's somebody that really knows a lot about this. When can I meet with her? So, Coping with Cancer 101. Emma also meets with our patients 101. And so the board of our foundation decided to provide for the first 10 patients to meet with Emma however many times they need to, 5 to 6 visits total, to see how this program is working, helping people cope with cancer. Do you need a nurse navigator? And the answer is yes. And fortunately, we have the best. We have Arrington, and we all know and love Arrington. So one of the reasons MD Anderson is so special is people say, I walked in the door and my nurse navigator met me, and they orchestrated the whole process for me. Well, Arrington can help with that also. Arrington knows everything there is to know about breast cancer, and Arrington can make things happen. So, we call Arrington Superwoman, but she also helps coordinate your care. One of her many responsibilities is to make sure that your doctors are communicating with each other and that the whole team is working together for your interest. Do you need a mentor? Our patients that have a mastectomy that do the best will meet with another patient that had the same breast cancer surgeon and the same plastic surgeon. And I've met with patients for hours and said, Bill, I learned more in 3 minutes from meeting with this woman that I could have learned in talking with you for 3 days. You've probably never had this operation. You probably never will have this operation. You don't seem to know how long the drains are going to be in. And I do know how long the drains are going to have it, but no one believes me because I'm not ever going to have one of those drains. But we've had patients that could not get to the operating room, and in 3 minutes of meeting with another patient, completely relaxed because they've met with someone that's been through it. And our patients are horrified when they find out they have cancer, and almost every one of them turns it into the next positive step of helping another patient. The Cancer Wellness Program here is second to none, and they've done an incredible job. They have lectures. You can meet with the nutritionist for 3 visits for no charge, or oncologic nutritionist trained at Hopkins. Who is Jennifer Munn, and where does she live? We're almost through. We're getting to the end. Jennifer Munn is a breast cancer nurse that is in charge of writing the national exam for certification of breast cancer nurses. So she goes and helps write this exam, and they say, so are you at Memorial Sloan Kettering or MD Anderson? She said, well, I'm in Piedmont in Atlanta, and have a seat, and I'm going to help you write this exam. So Jennifer's a great help. Jennifer worked for us 8 hours a day. She now has a 3-year-old. She lives in Fort Worth, Texas. She's working remotely for us from 10 a.m. to 1 p.m. But she's a stabilizing factor for us, and she's a huge help. Who are my partners? So Alex Steele is here. Alex did his breast cancer fellowship at Emory, has done an amazing job. There's a nurse in the operating room that said, you know, if you retire, I'm either going to have to call you back or twist Dr. Bowman's arm or twist Dr. Deal's arm. And she said, you know, I don't really need you anymore. You know, if you ever retire, you got 2 partners that can do the job, but I no longer need your number because if you're gone, I'm in good shape, which is exactly what you want to hear. And then Erin did her breast cancer fellowship, Erin, and Komen Foundation just asked Erin to, since she has so much free time, to be on their board, which is such a nice honor, and I'm very proud of Erin for doing that. But I mean, let's be honest about this. Breast cancer is a big deal, and you want a team that's skilled, and you need every single component. If the pathologist can't read your slides properly, the program falls apart. If you don't like the medical oncologist, people will say, you know, this is not working out. If radiation oncology, and of course us, surgery, the nurse navigator, the whole program is a team. And I will tell you something, a breast cancer patient can go anywhere in the world they want for treatment, and they want to know that the team is working together. And if the team doesn't have every single avenue covered, they will go wherever they want. I mean, there's a big airport in Atlanta, and people can go wherever they want. And so it's so important that this team work together. And I'll be honest with you, if you have surgery here, it's going to go better than just about anywhere else. And it's just a fact. And I'm sorry, but it's not because of us personally. But people go elsewhere for surgery, and they come back here, and I said, but almost no one goes elsewhere for surgery. But it's a family atmosphere here. But beyond the fact that our results are excellent, to be honest with you, the first day I went in practice, one of my partners said, Bill, if it works here for you, you know, you remember 3 things. You know, it's the last thing they figure out is your ability, but it's about affability and availability. But we make ourselves available, and all of our doctors are available to answer your questions at any time. And so I think that's pretty much it. What was that, like a 6-hour talk or?